Good evening, everyone. Thank you so much for joining our March DREF event, Pain Management in the Wake of the Opioid Epidemic. My name is Yvonne Collins, and I am the Chicago Citywide Coordinator for the Delta Research and Educational Foundation. This is our core team, mostly housed in DC. They really work diligently to ensure that our grant with the National Institute of Health goes well. These are the 12 cities that have been chosen around the country that do exactly what I am doing here tonight. The goal is to educate the community so that we can increase accrual to clinical trials. The campaign objectives are clear: to create awareness around various topics, today being the opioid epidemic, to encourage health and wellness in our community, with a focus on the African-American community.
So much of what we've done in medicine over the years has not really taken into account individual differences, and this is an opportunity to be part of something historic.
Most studies and most clinical trials have always been with the average white male. So as we start thinking about this in the context of building trust, I think we get back that trust by involving the community. Not saying you come to us or we'll just do things to you. We're going to do things with you and in fact allow that information to be accessible to you, the individual.
You're going to have some individuals that are going to say, yes, good, we're getting in on the ground level of a study. And then you're going to have those that have some trepidations about it. My thing is to bring them aboard and let them know that this is for the greater good for them. We have input, and without input, there's no buy-in. And without buy-in, there's no commitment. Without commitment, there's no success.
Tuskegee happened. We're not trying to hide that or sweep it under the rug, but communities of color will be at a disadvantage if we do not find ways to get by that. Whether the focus is asthma, whether the focus is infant mortality, whether the focus is diabetes, cancer or heart disease, communities of color are disproportionately impacted by them.
It has always been playing catch-up to make sure that they're even getting access, much less minimum service. Low income, underserved, and people of color are oftentimes very generous in giving something if they understand it. And they always do so with the intention that knowing this is not just about me, this is not just even about my family, it is about helping the community down the road.
Being able to bring the Asian American population who is never at the table, not only to contribute to science, but to contribute to our ability to understand the nuances within those populations. I think it will provide a huge national data set so we can ask questions and make discoveries about healthcare that will better their own personal health and those of the communities that they are part of.
Diversity strengthens the science. It could bridge some civil rights issues and inequities in healthcare across all races and ethnicities and culture.
As a community of color, underrepresented, hidden, underserved, what would happen if you were not at the table? It is an issue of equity, and it's an issue of justice as well.
It is important for minorities to be a part of this, or we will again be left with medications that are created for really other populations. I'm hopeful that we will be overwhelmed with folk.
You'll get to see a little later some of the numbers of where we are now. But the research program is really to improve healthcare outcomes and decrease healthcare disparities. And we're hoping to do that with precision medicine. And often you hear about precision medicine primarily in oncology, but now it has extended to so many different realms of imaging and cardiovascular disease. And so we know with precision medicine, we're able to better treat patients exactly how they need to be treated. Let's watch this video from President Obama on precision medicine.
Something called precision medicine, in some cases people call it personalized medicine, gives us one of the greatest opportunities for new medical breakthroughs that we have ever seen. Doctors have always recognized that every patient is unique. And doctors have always tried to tailor their treatments as best they can to individuals. You can match a blood transfusion to a blood type. That was an important discovery. What if matching a cancer cure to our genetic code was just as easy, just as standard? What if figuring out the right dose of medicine was as simple as taking our temperature? And that's the promise of precision medicine, delivering the right treatments at the right time, every time, to the right person.
So imagine that. This research program will really accelerate what we already know. I think everybody saw it during COVID, how quickly the vaccine came to market. But additionally, we hope to nurture relationships and dispel some of the myths that minority communities have with academic institutions, to understand the importance of relationship building and involving the community, but it's going to deliver the largest and richest biomedical resource that we've ever seen. We're already starting to see a significant number of publications. I think it's about 200 to 300 now that are based from the research within the database, which is phenomenal. The values are simple. It's what I think most patients would want: to be open, to be diverse, to be considered partners, for it to be transparent and accessible, to be secure, and ultimately to provide a positive change, not only for the patient, but also for those around them. You'll hear a little bit more about the process in terms of how you enroll when we speak with our HPO, but it really is a simple process. And so imagine with this research program, if we could develop pain medications that aren't addictive. You'll hear about some of that data today. If we can develop better treatments for diabetes or prevent diabetes altogether. If we could identify who's more susceptible to dementia or kidney disease and be able to intervene specifically, imagine the grounds we would make and the progress we would make in the field of medicine.
The All of Us research program is an ambitious effort to gather health information from 1 million or more people across the U.S. Researchers will be able to use this information to uncover new, more precise ways to prevent and treat disease and to keep people healthy.
If we delve deeper into where we live, what we consume, what we do, that will have an impact on trying to prevent diseases in the future.
Precision medicine will allow us to get the right medicine at the right time for the right person.
Diabetes, high blood pressure, obesity, illnesses that Black women get and die from needs to be researched.
This isn't going to be some sort of Tuskegee experiment. This is going to be the community working together with healthcare institutions.
So the promise to our partners who participate in this research program is to not only fight their disease, for them to learn about their own health, to be able to access their own data, and be the first to learn about additional research opportunities. So again, you can visit researchallofus.org to learn more. Additionally, just to remind everybody, over the 5 years for the program, the goal is to enroll 1 million participants. And when we say diverse, those are those categories of patients that have not been historically at high volumes in clinical trials. So Blacks, Hispanics, Asians, seniors, the LGBTQ+. Is to expand it using surveys and health streams and some genetics, but begin to look at the environment in addition to physical factors that play a part, we know, in disease. Additionally, the goal is to create a community of researchers that use the data, but really a focus also on researchers of color who look like those underrepresented minorities, to continue to build that, not only the database, but the source of researchers that use that data that may study those participants. And so locally, we have partners who you see here on the screen. I'm so excited to have Rasika here today, who's a research assistant from Northwestern, who is one of our health partner organizations. Rasika, you can come off mute and let me know when you're ready for me to advance the slide.
Hi, everyone. Thank you so much for the wonderful introduction, Dr. Collins. I am Rasika, and I am a research study assistant with the Northwestern site. And we appreciate you taking the time to be with us and learn more about the All of Us research program. I will be sharing a few more details on how to sign up for the program, as well as what to expect and what our numbers are looking like today in the midst of year 5. Currently in Illinois, we have several institutions working to support this effort, and we are known as the Illinois Precision Medicine Consortium. Here you will see a concise view of our participant locations throughout Illinois. And here on this slide, we can discuss what does participation in the program look like. And participation is made up of 2 parts, online and in person. If you are a smartphone user, the simplest and fastest way to download the All of Us application on your mobile device. Alternatively, you can use our website at joinallofus@illinois.org. There, the mobile application and website is where you will create an All of Us account online. And this account is also known as the participant portal. It is referred to as the digital dashboard for the participant journey. We do encourage all participants to complete the online portion before an in-person appointment to decrease the amount of time spent in our participant center. However, this is not required and you do not have access to, if you do not have access to a smartphone or internet, the online portion can also be completed at any four of our participant centers during your in-person appointment. We also offer telephone appointments to help participants through this first component of the program remotely. And participants are able to view activity and data shared within the participant portal at any time. When you come into one of our participant centers, you can expect the following. If the online portion has not already been completed, participants will share and be asked to consent immediately after creating an account using an active email or mobile phone number. The consent process is an interactive journey that includes a series of screens and videos explaining the program and participant rights, including available transcripts, consenting documents that need to be read and signed by the participants. All consents can be accessed and updated at any time through the participant portal. If you choose to consent or to share your electronic health records as a participant, you will be asked to provide a witness. And this can be any individual over the age of 18 who can confirm that you are who you say you are. And if you aren't able to have a witness when you are navigating the online portion, you are able to schedule an in-person visit and one of our staff will be able to act as your witness. Next, you will be asked to complete a series of surveys. Survey completion is what will provide researchers with an understanding of what your life is like on a daily basis in your environment, including information concerning how you exercise and what you eat. And surveys are an important part of staying connected with participants and hearing about the changes in life over time. Participants will be given a list of nearby sites which they can partner. After selecting your desired location, you will then have the opportunity to schedule an in-person visit, and this portion will take approximately 30 minutes, which includes basic physical measurements such as height, weight, hips, and waist circumference, and blood pressure. And you can think of this appointment as a mini physical. Afterwards, you will also participate in a biosample collection, including blood or saliva or urine. Afterwards, you will receive $25 as a gift card. Lastly, participants can answer SNAP questions and even sync or view data from supported third-party devices such as Fitbit and Apple Health. Both serve as additional sources of data collection. Because the All of Us research program is a longitudinal study, there is large value in receiving multiple data points for participants over time to have a full understanding of what the various factors that make your health story, because what works for one participant may not work for the next. And you can proceed to the next slide. As a part of our core values, one moment. The All of Us research program is committed to ensuring that participants have the chosen ability to share the information and receive the information. For example, many participants have expressed a strong desire to understand what DNA can tell them about their health. The first DNA results returned to participants are ancestry and non-health related trait reports. If participants consent to receiving them, they will access trait and ancestry results separately and decide which ones they want to see. Through the web-based genetic engagement module, or the GEM, all of us participants will easily navigate and view DNA results, including traits, ancestry, and health-related results. It is through the GEM that participants will have access to educational materials, live phone support, and an escalation path to the Genetic Counseling Resource Center, specifically for all participants choosing to receive a DNA health-related report. Scheduling a GCR appointment will be available, but not mandatory to view the report. The GCR can help participants connect to local resources that can work for them and also help facilitate discussions with loved ones and their family members. And you can proceed to the next slide. Safety is our top priority. We will ask that you use one of the masks provided by the hospital, found by every entrance, and complete a health screening during your check-in. We also have a cost service called Kaizen Health. They partner with Lyft and Uber to have dedicated drivers for medical appointments. If you need assistance getting to your appointment, we may be able to schedule a ride to and from the center with the service. If you prefer to drive, you will cover the cost of your parking in our garage. And once you arrive, one of our staff will meet you at the check-in so you don't have to worry about getting lost. It is important to note that our participant centers have implemented new policies and procedures to meet all local, state, and federal guidelines. This may vary slightly site by site, but include universal masking and physical distancing, self-reporting of any health symptoms 3 days prior to appointments, additional health screening upon check-in. And you can proceed to the next slide. And here are some of our data snapshots. As you can see, we are more than halfway towards our goal, 1 million or more participants. So far, we have over 613,343 participants consented, and also 49,897 in Illinois for the completed initial consent. For our core participants, we have 426,882 participants have completed their consent and health surveys and in-person appointments. And also we have 40,339 in Illinois. Moving on to the green section to the right, we highlight our UBR numbers. The All of Us Research Program defines populations that are underrepresented in biomedical research. UBR as groups are defined as historically not well represented in biomedical research, including clinical trials. Currently, 78.63% in Illinois, and currently for the All of Us research participants fall into this category. Racial identity currently stands at 67.46%. And lastly, we move on to our researchers' data, in which there are 449 registered institutions, 3,198 workspaces created, and 3,892 registered researchers. And the program continues to grow since its launch. And if you have further questions about the All of Us Research Program and how to join, or if you're interested in learning more about what the participation entails, please feel free to contact us using the information that will be provided in the chat shortly. And thank you so much for taking the time to allow us to present here. And I'll pass it back over to you, Dr. Collins.
Thanks, Wasika, so much for joining us. Thanks. Again, you can join any of our social media platforms to learn more on Instagram, Twitter, or Facebook. And of course, you can always contact me via email or phone as your Chicago citywide coordinator. I must read this disclaimer before we move to the main event. The views and opinions expressed by the guest panelists and/or presenters do not reflect the views or opinions of the Delta Research and Educational Foundation, DREF. DREF Research Matters for All of Us, the NIH All of Us Research Program, or any of these affiliates organizations. Again, I'm so excited to have Dr. Penmecha here today, who's the Division Chair of Acute Pain and the Associate Program Director of the Pain Fellowship in the Department of Anesthesiology and Pain Management at Stroger Hospital. I'm going to stop sharing so she can start to share. She's also an assistant professor of anesthesiology at Rush University here in Chicago. She earned her medical degree from Sawi Man Singh Medical College in India and completed her anesthesiology residency and pain fellowship at John Stroger Hospital, and currently serves as a member of the hospital-wide opioid task force with the goal to ensure safe opioid prescribing practices. Dr. Penmecha, thank you very much again for joining us, and I will turn it over to you.
Thank you, Dr. Collins. I am really excited to be a part of this program. This is a good initiative, and I think it is really, really important for us as providers to be aware of this devastating catastrophe that we are facing. So I'm going to talk about pain management in the wake of opioid crisis. This is my lecture outline. I'm going to elaborate on the opioid crisis that we are experiencing. I'll talk a little bit about pain crisis in US, and I will talk about the role of pain management medications such as opioids in the management of acute pain. I'll also talk about a little bit about what is chronic pain and what kind of management options do we have available to treat these patients. The next thing I will talk about is a little bit on addiction and the MAT program, which is the medication assisted treatment programs, and what are the initiatives that Cook County Hospital is taking to help us curb this epidemic. So what is opioid epidemic? The increasing number of deaths that are related to opioid overdose are termed as opioid epidemic. And what is the reason for this? The reason is multifactorial. There is a percentage of patients who are probably exposed initially to illicit drugs like heroin, and now the drugs are mixed with highly potent opioids which are addicting, such as illicit fentanyl and other illegal opioids. The other group of patients are the ones who are exposed to opioids, and their first exposure might be because of the legal prescriptions of opioids. In America, almost 20% of the opioids that are prescribed are being abused. And this happens because either they are getting more prescriptions or high potency opioids for management of non-cancer chronic pain. So how did we get here? In the 1990s, the thought was that opioids do not cause addiction, and pain management for pain was supposed to be the fifth vital sign and needed to be treated. And this led to a mass production of opioids by different pharmaceutical companies and physicians prescribing opioids for management of non-cancer chronic pain. And this led to people developing tolerance to opioids, requiring more and more opioids, and it increased the illicit use of opioids also. So presently, 2.7 million Americans have opioid use disorder, where they are using opioids and they have significant impairment or distress because of these medications. It is staggering statistics to see that 80% of the overdose deaths that happen, they happen because of opioid medications. There are three distinct waves of opioid epidemic. The initial wave started in 1999, when the opioid prescriptions increased and there were opioid deaths related to legal, lawful opioid prescriptions. Then in 2010, there was a rise in heroin as the opioid that caused deaths. Recently, there are drugs that are called IMFs, or illegally manufactured fentanyl, which has been causing a lot of opioid deaths. So in the last decade, the overdose deaths in the US have reached an epidemic number. Almost 100,000 drug overdose deaths were reported by CDC in the year 2021. That is almost 180 people dying per day of opioid overdose. This is amazing to look at these numbers. when I was making the lecture, I looked at this data and it was surprising to me. Almost 80% of the global opioids are consumed in the United States. So do we think that other countries, people do not have pain, they do not get surgery? Why is that? I'm going to go briefly over the drugs that are abused. The alcohol and marijuana they are on the top, almost 20% of the drug use is because of alcohol and marijuana. And then it is followed by the pain relievers, the opioid pain relievers that are prescribed or they are abused on the street. There are other drugs that are abused like hallucinogens, depressants, some stimulants, and methamphetamines. So these drug of abuse, some of them have medicinal indications, and that's why they're either prescription drugs. Like marijuana, now it is legally available in many states, not just for medicinal reasons, but also it can be recreationally used. Although short-term impairments can cause distorted perception, but long-term these medications can result in memory impairment or even in cognitive dysfunction. The opioids, even heroin is also an opioid, and these drugs are used to decrease the perception of pain, but they can cause drowsiness, confusion, respiratory arrest, and also obviously addiction that we are going to talk about. There are some drugs that are stimulants which are used medically for treatment of ADHD like Ritalin and Adderall, but then there are some stimulants like cocaine that are used on the street. And these drugs make you feel alert, they make you feel more attentive, and they increase your energy, but then they elevate your blood pressure and heart rate, and they can cause you to eventually have heart attacks. There are some drugs which are called hallucinogens, and these drugs are used in medicinal reasons, like ketamine is used for anesthesia, and it is used for management of depression and PTSD. What do these drugs do to pregnant women? This is a special subset of population because drug use not only affects the mother, but it also affects the babies. So when the mother is using drugs, they can have miscarriage, they can end up having preterm labor, poor growth for the fetus. And when the baby is born, they may present with withdrawal symptoms. These babies may have birth defects, they can encounter sudden infant deaths. And also later on in life, they may be experiencing cognitive and behavioral problems. Also remember that if mothers are using drugs IV, they might be exposed to HIV and hepatitis C, and these infections can be transmitted to the baby through the placenta. Look at these statistics. Every 15 minutes, a baby is born who's suffering from opioid withdrawal. What is opioid withdrawal? These are the babies who are exposed and they are getting a supply of opioids while they are in utero. And once they are born, the supply is cut off. So these babies go through withdrawal. These babies may be jittery, they may have seizures, they may require monitoring after birth. And it is important to understand that during pregnancy, if women are using opioids, that is illicit drugs, then they should be managed in medication assistance treatment programs to decrease the risk of overdose death and to prevent relapse in this population. Now, that was a little bit about the opioid crisis. Now, on the other hand, what is pain crisis? So if we look at these numbers, these are staggering too. Chronic pain affects more Americans than heart disease, diabetes, and cancer all grouped in one. So it can cause substantial morbidity, mortality, disability in millions of Americans. And the consequence of pain does not only impact the patient, but it impacts his family, his work life, his social life. So it is important to treat pain. There is some data here. Almost 100 million Americans live with chronic pain, and 20 million are not even able to perform the basic functioning or activities of daily living or even perform their personal hygiene. So pain is one of the major reasons why healthcare systems are accessed by patients. And also it can cause long-term disability, and this is the #1 cause for disability in America. If you look at the cost, almost $635 billion are spent annually, not just on treatment of pain, but also because people are not able to go to work. So they might be on disability, they might be taking other assistance, they might from the government, and this is a big, big cost to the American society. So what do? Do we treat the patient's pain? or we let them suffer so they do not get addicted. It is a very tight rope that clinicians are trying to help the patients with chronic pain. They are either trying to ease the patient's suffering, but at the same time, they have to be mindful of the risk of using opioids to manage pain. There are some options that are non-medication options. There are options that can be used to manage chronic pain, but they may be sometimes hard to get, or people are not aware of it, or the insurance companies might not be paying for it. So it is very hard to find the balance between treating patients and to prevent addiction. So I'm going to go and talk a little bit about pain so we understand that there are different kinds of pains that should be treated differently. Not every person suffering from pain is the same. So a lot of times we talk about pain, it is an unpleasant sensory and emotional experience. This is associated either with actual tissue damage or with potential tissue damage. So pain can be classified. The most common way that we classify pain is we look at the scale from 0 to 10 and we say that the pain is mild or moderate or severe and we manage it accordingly. Everybody is familiar with that. But then we have to understand what is the pathophysiology of pain and what is the duration of pain and classify it that way so we are able to appropriately treat it. So this is about the pathophysiology of pain. I'm not going to go into a lot of medical details, but the simple thing is pain can be nociceptive pain when there is injury to the tissue, like there is fracture or the patient goes through surgery, there is tissue that is injured and the patient has pain. That is called nociceptive. Then there are patients who may have nerve pain or neuropathic pain that comes from injury to the nerves, like a patient who has a stroke or a patient who has spinal cord injury, or a patient who has neuropathy because of diabetes or has shingles. The nerves are injured and they are going to cause pain. Is it easy to classify pain in just these two different settings? No, because a lot of complex overlap exists between different kinds of pain, and patients may have both kinds of pain combined together. So as long as we know the etiology of pain, it is easy for us to manage us accordingly. Then pain can also be classified as acute and chronic pain. This is very important for us to understand. Acute pain is the pain when there is injury, there is pain, you treat the pain, the injury heals, and the pain goes away. This pain does not persist for a long time. Versus there is chronic pain. This is the pain that can persist for longer than 6 months, and it persists beyond the healing process. You had surgery, 3 months down the line, the surgical scar has healed, but still you continue to have pain. That is called chronic pain. In chronic pain, patients start getting changes in their nervous system. There are some structural changes, there are functional changes, and it is important to understand that therapies that you use for management of acute pain may not work for chronic pain. The chronic pain can be affected by many, many different factors. These patients who are in pain for more than 3 months, they will have work stress, they may have family stressors, they may be feeling depressed, or they may be anxious, they may have poor sleep, poor appetite. Because of the injury, they may not be able to move their limb, they may not be able to, or they may be having joint stiffness, or they may be having weakness or spasms, and all these things perpetuate the pain cycle. So it is important to treat the pain with all these factors into consideration so the patient is able to become a functional member of the society. This is again the diagram of the pain cycle. There are some physical factors and psychological factors, and it becomes a vicious cycle, and it's hard for patients to cope with this pain. So chronic pain is a disease in itself. We have to treat it as such. So why this is something that I want to bring up. We are a pill-centric culture. What do I mean by that? It is very easy to pop a pill and get rid of the pain, then find out the cause of the pain and find out what is the problem and solve the problem. The quick fix solutions are very alluring and they are convenient. You pop a pill, pain goes away, but they don't solve the underlying problem. And that is very, very important concept. Once you solve the problem, the pain will go away instead of just popping the pill to mask the symptoms. We know that opioid analgesics are required to treat acute pain, but effectiveness of opioid analgesic in treating chronic pain that persists for long periods of time and not associated with cancer or end of life is very, very questionable. The opioid use is very questionable in these patients. So there is a link between long-term use of opioid and addiction and overdose death. So we have to understand that. What is the role of opioids in pain management? Do they have a role? Of course they have a role. Opioids are effective in treating acute pain. You go through surgery or you have a fractured arm and you need pain medicine. So opioids are pain medicines that should be used for a short period of time. Or they can be used in flare-up of certain conditions. Patients with sickle cell disease who come in and they are having a crisis. You will need some opioids to manage that pain. Patients who are dealing with cancer and patients with end-stage diseases, they will need opioid management. But in chronic pain, opioids do not correct the problem, and they actually add on to the problems that happen in the nervous system, that dysfunction that exists in chronic pain. So it is very, very important to use these medications judiciously and understand the problems that come around with chronic pain. So now we should be moving beyond pain scores. What do I mean by that? Pain is 0, we don't have to treat it. Pain is number 3, we are going to give them non-opioid medicines or over-the-counter medicines. And pain is a 10, let's give them opioid. That concept has changed. Pain is no more viewed as a linear experience. It is a multidimensional experience that is evoked by the nervous system. Then it is important to understand pain in terms of intensity, pathophysiology, complexity of symptoms. What other problems does the patient have? Whether this patient is a functional member of the society or he is bedridden. So there are many different aspects of pain, and we have to see it as a multidimensional experience and treat it as such. So initially, WHO came up with this analgesic ladder in 1986, where they said if the patient has low pain, mild pain, let's treat them with non-opioid. If the patient has severe pain, let's treat them with strong opioids. This concept has changed. WHO said, no, let's add some invasive interventional procedures to this problem. But then recently, now we understand that pain is a multimodal, multidimensional experience. So we should treat it as such. We should treat it using multimodal options. So I'm going to go with this newly interpreted analgesic trolley model. If you look at this, this is a cart that has all the different options, from education to non-opioids to opioids to injections to neurostimulation to physical therapy. And this is different options of pain management for chronic pain. And that's what I'm going to go over in a little bit. So these are, first I'm going to talk about non-pharmacologic options very briefly, then I'll talk about the pharmacologic options, including opioids. The non-pharmacologic management options, there are some behavioral approaches that can be utilized, like CBT. There are approaches that are movement-based approaches, like physical therapy, or going to the chiropractor, getting spinal manipulation, or doing yoga and Tai Chi, versus there are some mind-body interventions, which are good for decreasing the stress related to chronic pain. And you can also do acupuncture and other options. The physical therapy, we all know there is substantial research that says that physical therapy is a viable option for management of pain. Movement improves the function, range of motion, but also alleviates debilitating pain. So it is important to keep your joints moving, to improve muscle strength, and send patients for physical therapy. Some therapists may use a TENS machine. It is a small machine with electrodes that generates a small, tiny bit of current. And this machine sends electrical impulses to the brain, and it reduces the sensation of pain. The stimulation also releases some pain-relieving substances in the body, which are called endorphins, and that also helps the patients with pain. How about mind-body exercises? Why are they better? Are they better or they are worse than physical therapy? Some patients are not able to participate in aggressive physical therapy. So these are exercises which are utilizing slow motion and weight shifting, and these improve your flexibility, and these improve your strength. And research suggests that yoga also improves mood when patients who are saddled with pain. How about massage therapy? Yes, massage therapy is helpful in some patients because it relaxes the muscles and tendons and joints, and it can relieve painful contractions. In 2018, CMS actually announced that many Medicare plans would cover massage therapy for pain management. How about heat and cold therapy? Yes, these can be utilized. Cold therapy is important in acute injuries where there is a lot of inflammation. It can decrease the inflammation, whereas superficial heat can be utilized to increase the blood flow to the area, to increase oxygen delivery, and that helps with the extensibility of the tissues. So these are common things that we can implement before we jump to treat patients with pain medications. How about cognitive behavioral therapy? It is a form of talk therapy. The patients who are suffering from chronic pain, they develop a lot of negative thoughts, and the CBT helps develop skills that can change the negative thoughts and behaviors. And it helps patients cope not only with pain, but with depression, with their anxiety and other health conditions. How about acupuncture? Acupuncture involves placing small needles to the skin at different points that are strategically defined all over the body. Earlier, I did not believe in acupuncture till we have acupuncturists doing acupuncture for the patients in our clinic, and you see the response. These patients do very well with acupuncture, and it works by releasing endogenous endorphins. Those are natural painkillers that are released in your body, and it helps control both acute as well as chronic pain. Now, Medicare has approved 6 sessions of acupuncture with physician referral. So let's talk about a patient story. LT is a cashier who started having neck pain, maybe related to the job, maybe related to the posture that he sits in all day. And this became a daily condition. He could not function well at work. He was started on physical therapy and TENS therapy after an X-ray showed some disc degeneration and arthritis. Now LT is back at work and he continues exercises to minimize pain and stiffness. These are true stories of our patients. I just have changed the names. Now, moving on from non-pharmacological therapy to pharmacological therapy or medications, I'm not going to delve deep into the pathophysiology and mechanism of every medicine, but I'm going to give a brief overview. So this is an important slide for everybody to understand. So this is our skin or muscle or joint that has injury. And then the nerves take the pain all the way to your spinal cord, and then it is perceived in the brain. So there are multiple targets where you can use these pain medications. You can use them at the level of injury. There are medicines that can be used like local anesthetic or NSAID medications, aspirin, Tylenol, even capsaicin creams that can be applied to the tissue to help with the pain. Then you can block the transmission of pain by using local anesthetic and doing nerve blocks. And that way the pain is not carried all the way to the brain. Or you can block the transmission at the level of spinal cord by certain medicines that belong to local anesthetic or alpha agonist category. Then you can change the perception of pain in the brain where the opioids work. The perception is changed and you don't feel the pain. Then there are some medications that work on modulation. Modulation means there are some substances that are secreted by the brain that help in blocking the pain. And there are some medicines that work that way. Now, these are the commonly used medications that are called non-steroidal anti-inflammatory medicines like ibuprofen, diclofenac, naproxen that are easily available over the counter. These medications help decrease the inflammation and manage pain. There are some side effects that we have to be careful because these medicines are easily available over the counter and you may overdose yourself if you're trying to treat pain by taking them for long periods of time. These medicines can cause stomach upset, gastrointestinal upset. They can cause kidney problems if they are used long term. So we have to be careful. Patients who have heart problems or cardiovascular disease, these are probably not the safest medications because they can increase your blood pressure. Now, how about medicines for nerve pain? These medicines are not the same. They are not opioids. They are not the same kind of medications that are used for management of an injury. So nerve pain medicines are medications that are used for management of seizure, like gabapentin. There are medicines that are used for management of depression, like tricyclic antidepressants and some serotonergic drugs. So some of these drugs are gabapentin and pregabalin. You might have heard these names. These are commonly used for management of nerve pain, and some of the serotonergic drugs like duloxetine and venlafaxine that are used in the treatment of depression, they are also used for management of nerve pain. And our understanding should be to understand that these medicines can cause sedation, they can cause some drowsiness, and it is important to understand that using them with opioids can just worsen the side effect profile. There are some medicines that can be used as topical treatment, like lidocaine cream or capsaicin cream, and they also come in the form of patches that can be utilized for management of nerve pain. How about muscle relaxants? This is a very common medicine that is prescribed when you have acute injury and you are experiencing spasms. So there are a list of medicines that belong to this category. They work on by working on different receptors, but all of them cause some sedation and confusion and drowsiness. So they should be used carefully. This is another story. Mr. Sweet has neuropathy because of diabetes. His feet feel like he's walking on hot charcoal, and he is irritable all the time. So he was given Vicodin for pain, which is a strong opioid, but this caused constipation but did not help with pain. So he saw a pain physician and he was started on the nerve pain medicine, which is called gabapentin. He was also sent for acupuncture and he had ketamine infusion in the clinic. And Mr. Sweet is a sweet man all over again. Now moving on from non-opioid medications to opioid medicines. So these are some of the opioids that we see all the time, including morphine, fentanyl, hydrocodone, which is also known as Vicodin or Lortab or Norco. Then how about oxycodone? These are strong pain pills. And this table kind of shows how morphine compares with the other medicines. So there are some medicine, if you look at the size here, morphine is a number 1, so hydrocodone is number 1, oxycodone is 1.5, and hydromorphone or Dilaudid is 4 times as potent. So we have to understand that some of these drugs are extremely potent, and as providers, when you are prescribing these medicines, you'd want to stay with the lower potency agents first and not expose patients to high potency drugs because the risk of addiction increases as the potency of the drug increases. What are the side effects of these medications? Some of the side effects we know already. These may cause sedation. They may cause respiratory depression and even respiratory arrest if they are not used appropriately. They can cause constipation. They can decrease the immunity. And obviously, the problem that we are experiencing, the epidemic that we are experiencing, is because these drugs are highly addictive. So continuing with the opioid side effects, like I said, these drugs can cause dependency and they can cause addiction. What is dependency? Dependency is your body gets dependent to these drugs when you use them for a period of time. So if you're using and you stop it all of a sudden, you may start feeling withdrawal symptoms. So your body is physically dependent to these drugs. On the other hand, there may be addiction. Addiction means you're not just physically dependent, but you're also psychologically dependent on these medicines. And it is an urge to get this medicine, even if you're having significant problems. You may sell your house, you may sell your car, you may lose your arm and leg, but you still want to get the drug. That is called addiction. So addiction is a disease. It is something that we should treat as such. It is classified as a DSM-5 in DSM-5 criteria as a disease. This is important to understand that, if you say diabetes is a disease, out of 100 patients, maybe 85 to 90% of the patients get some treatment for it. But when you talk about addiction, if there are 100 patients suffering from addiction, only 10% are getting treated for it. So we have to remove the stigma that addiction, this is a problem that the patient created for himself. We have to treat it as a disease and treat these patients and get them enrolled into medication-assisted treatment, try to help them so we can get rid of this opioid epidemic. So what is medication-assisted treatment? There are some medicines that are approved by FDA to treat these patients who are suffering from addiction. It is important for us to spread awareness about these medication-assisted treatment programs so patients can live a successful and productive lives. Some of the drugs that are used are buprenorphine, naltrexone, and methadone. These are the most commonly used medications, and they work differently. I will go very briefly over these drugs. So methadone, we all have heard about methadone because of the methadone clinics, and it has been in use for a long, long period of time. So it is an opioid medicine like morphine, but it is used to treat addiction. It works on mu receptors, which are the opioid receptors. It also works on NMDA receptors, and it blocks them, which are pain-producing receptors. So when methadone is used orally, it prevents withdrawal for 24 to 36 hours. and it reduces the craving. So if you were to take morphine or oxycodone, you would still crave for the drug, but when you take methadone, you don't get the cravings. So that's why it is easily used to block withdrawal, and the patient does not feel like has a need to get more and more and more. Methadone, it is important to understand that methadone is also a painkiller, and it can be used for management of pain. It is a very strong drug that can be used for management of both cancer pain, or management of neuropathic or nerve pain. When you use methadone for pain, you have to be careful because it doesn't work for the whole day like it works for addiction. You use the same dose and you give it in divided doses, so the patient is much more comfortable. How about buprenorphine? Buprenorphine commonly is called Suboxone, and it is also used for management of addiction. It works on the opioid receptors also. It is also an opioid, but it is a partial agonist. It attaches to the receptor, but does not activate it all the way like an opioid would. So what happens is it has a less addictive potential, and it causes less physical dependence, and it has less potential for abuse. So these patients who are in Suboxone treatment, they don't feel the urge to use opioids. Also, compared to methadone, which the patient has to go to the clinic every day to get the dose, with buprenorphine, they can get the medication from the clinic. So it is easy for the month supply. So it is easy for the patients to have better compliance. This is how you initiate buprenorphine. It is important to understand that you cannot give buprenorphine to somebody who's actively using opioids. You have to wait, take the patient off the opioids for a few days till they start showing signs of withdrawal, and then you start the buprenorphine. So you have to do it in a clinic setting or a little bit more monitored setting where you treat the patient's withdrawal using other medicines and then start Suboxone. This is another drug that is utilized by, which is approved by FDA for management of addiction. It is called naltrexone. So naltrexone is a little bit different than methadone and Suboxone. It is a blocker of the opioid receptor. It blocks the opioid receptor, so no other opioids will work on it. So if you are having patients who have overdosed on opioids, you can use these blockers like naloxone or naltrexone, and they will treat these patients and they will block the effects of opioids. So it can be used as an antidote too. But the good thing about naltrexone is it can be used as an IM dose, intramuscular dose that lasts for up to a month. So if you give the patient this medicine, they have to go monthly to the doctor to get this medicine, or it can be implanted as a small subcutaneous pump, which can last for 9 to 12 months. So it definitely increases the compliance of the patient. So they don't have to go to a clinic every day to get the medicine or every month to get a prescription. They have this implant and they forget about it, and none of the opioids are going to work. So they are not going to get addicted. They are not going to have cravings, and they will not be overdosed. So this is a table showing the same thing. These were methadone and buprenorphine are agonists. They work like opioids. Naltrexone is an antagonist. It works against the opioids. And these medications do have some adverse effects because the first two are opioids. They can have similar side effects like opioids, but naltrexone can sometimes cause withdrawal in patients if they start taking opioids because it is an opioid blocker. All right, so now I'm going to move on to this opioid safety. When you are taking opioids or when you are prescribed opioids, it is important to follow certain safety recommendations. You should never take opioids in amounts that are higher than prescribed. Opioids should be stored in a safe place, out of reach of children, out of reach of other members, so nobody else gets addicted to them or nobody else uses it and abuses it. You should not sell your opioids or not share prescription opioids. We see a lot of times the patient comes to us and they ask for a particular medicine because they borrowed it from a family member and it works for them. So it is very important to understand that you don't know what it is going to interact with, what your metabolism is, how your body is going to treat this drug. So never share your prescription opioids. If you feel that you need the opioids for pain management, talk to your doctor and see if that is the right choice for you. Do not combine opioids with alcohol or other drugs that can cause drowsiness, such as benzodiazepines or muscle relaxants or sleeping aids, because the effect is going to be additive and you may stop breathing in your sleep. Also, if you are prescribed opioids for a fracture or surgery, you have medicine left over, bring it back to the pharmacy. They have take back programs. And that way you are not going to have these opioids available for your kids to abuse or somebody else to use it by accident. All right, now I'm going to move into a little bit about interventional management. What that means is injections or plain blocking techniques that can block pain. These are non-pharmacologic management. There is no medication that is being prescribed or no pills that are being prescribed. A lot of different procedures are done, a lot of different interventions are done. Some can be minimally invasive and can be a little bit more invasive. There are nerve blocks, there can be infusions, there are epidural and joint injections, even radiofrequency ablations that are done. Sometimes pain physicians will place spinal cord stimulations or peripheral nerve stimulators. These are all different kinds of interventional techniques. So one of the most common that everybody has heard about, even in OB, pregnant women, they get epidural injections. Sometimes epidural injections are done for pain management. During these procedures, we inject steroid medicine, which is anti-inflammatory, close to the nerve that is being irritated by a herniated disc, and this can give pain relief. All right, I like stories. They make a better impact. People relate to them. So Mr. B is a 54-year-old patient. He had back pain for 10 years due to herniated disc. He tried medications, including opioids, which gave him a lot of side effects. He came to the pain clinic. He received an epidural steroid injection, and he walked out of the clinic with no pain. And he came back for a follow-up appointment in 3 weeks. And at this time, his pain was still controlled. So we referred him to an ongoing physical therapy program with a follow-up appointment in the clinic. How about radiofrequency? This is another procedure that we do in the pain clinic for neck pain, back pain, when you have arthritis in the knees or hips. This can be a very beneficial procedure, which can give you relief for 6 months to sometimes up to a year. This is a minimally invasive procedure done with needles. We apply heat to the nerves, targeted nerves that carry pain. So this is Mr. CD. He was working as a heavy equipment engineer, and he started having a lot of knee pain. So initially medicines were helping him, physical therapy was helping him, but then the pain over time got worse. It was impacting his work, it was impacting his quality of life, his activities, and he underwent a radiofrequency ablation in the pain clinic with complete relief of his pain. There are some other therapies that are more regenerative or healing kind of therapies. One of them is called extracorporeal shockwave therapy. Another one, it's called platelet-rich plasma therapy. These are becoming more and more popular, and hopefully insurance coverage will improve for these therapies, because these not just cause pain relief, but they actually cause healing of the tissue. And what about neuromodulation? This is one of the newer technologies that has come into existence, and we are doing it a lot more. This is a small device that is placed, and it stimulates the spinal cord. And this prevents the pain signals from reaching the brain, and it helps the patients manage their pain without using any medications. So this is a story of a nurse. AK, she's a mother of 2. She's a registered nurse, and she injured her back at the age of 32 while she was lifting a patient at work. And she spent many, many years in pain. She underwent 5 surgeries on her back. And despite the surgery, she continued to have pain. She was started on opioid pain medications. She became dependent, and she actually lost her job. She underwent a placement of spinal cord stimulator. And at this point, she takes no medications. She works as a full-time nurse, lives a full, active, and pain-free life. So it is important to understand that there are other things that can be done besides just managing pain with opioids. So this is a little bit about our pain clinic. We are a multidisciplinary pain team. We have 2 sites presently at Stroger and also at Blue Island. We are a group of interventional pain physicians. Most of us are anesthesiologists. We have physical medicine doctor on site. We have a pain psychologist on site, and we have an acupuncture team consisting of 4 acupuncturists. This is a little bit about the opioid stewardship program that Cook County is leading to curb the opioid epidemic. So Cook County Health is committed to prescribing safe opioids so the right patient can receive the right opioid for the right indication, for the right length of time, and at the right dose. This opioid stewardship, it has three components. The first important point is to improve the pain management. The second is to prescribe the opioids safely and prevent overdose. And third is to identify these people who are experiencing opioid use disorder. And once you know these patients, you put them in a treatment program. So these are the three components, and we have an opioid task force that was started in 2016, and it is trying to work with all the providers, all the staff members, all the patients to increase awareness about those three components. So this is what the opioid task force does at Cook County. We are utilizing multimodal treatment to manage pain. We are educating all providers and patients on safe opioid usage. We want to reduce harm of opioids, so we identify at-risk patients. We are doing naloxone prescriptions, and we are doing on-site dispensing of naloxone to high-risk patients. We have access, all providers have access to prescription monitoring program, so we can see what the patients are on or what they are taking from another provider in the state of Illinois, so we can safely manage these patients. Also, identification of opioid dependency is important, addicted patients is important, opioid use disorder is important. So early detection is important, and then we can transition them to a medication assistance program so they can get some help and be productive members of the society. So I'm going to end with a little bit of recap. Pain is a multidimensional experience, particularly chronic pain, and we should use multimodal, multidimensional therapies. We should use opioids judiciously to control the pain and minimize the risk of opioid addiction. Chronic pain causes structural and functional changes in the brain and the nervous system. Therefore, therapies that are used for management of acute pain, like surgery pain or fracture pain, should not be used for management of chronic pain. Try multimodal. All the aspects of chronic pain should be addressed to give the patient a better experience. Opioid addiction is a disease. Treat it as such. Try to get these patients into medication assisted treatment program. The MAT or medication assisted treatment decreases illicit opioid use, it prevents relapse and decreases overdose related deaths. Thank you.
Thank you so much for a comprehensive presentation. We do have a few questions. And again, if you feel the need to ask a question, you can either put it in the chat or you can raise your hand and be acknowledged. The first question came across related to, you mentioned sickle cell disease. We know that there's a population that gets a lot of opioid usage. Do you recommend some of the non-medicinal therapies that you mentioned? Do you recommend those in that population also?
Definitely. So opioid sickle cell disease has two parts. There are patients who have sickle cell disease, and then there are patients who come in a crisis. So when these patients come in crisis and they may have severe pain, we do use opioids in these patients. But the patients who are doing okay with sickle cell disease, when they are not in crisis, we suggest using pain pills only as needed. These patients may have other symptoms of the disease. They may come with avascular necrosis of the hip joint or knees or other chronic pain conditions for which we have patients who benefit from interventional radiofrequency ablation at the hip joints. And we do acupuncture for these patients with significant benefit. Physical therapy is important. Definitely non-pharmacologic management. These patients may have nerve pain because of significant degeneration in the joint. The small tiny nerves that are in the area can be affected, and neuropathic pain medications will be beneficial. So every patient should be treated in a multidimensional, multimodal way.
Perfect. Before we go to the next question, you'll see a link tree in the chat. That's the survey for this particular presentation. I'll ask that you click on that link, go down to the evaluation survey, and let us know your thoughts of this program or other topics that you would like to hear about. There's one question in the chat related to lofexidine for opioid withdrawal. Are you seeing it used currently?
So lofexidine and other alpha agonists sometimes are used to manage the symptoms of withdrawal. So let's say the patient comes in to the hospital and is admitted, but he was actively using heroin or other substances before he came in. And you plan to start this patient on Suboxone or buprenorphine. But at this time, you want the patient to be off the opioids for a few days before you can start an MAT program. So you would like to use maybe clonidine or lofexidine to prevent the symptoms of withdrawal. So that's where we see it being used. It is not a part of the MAT. It definitely is a part of the MAT treatment, but it is not a medication that you will use for preventing relapse or doing the transition. It would be used to manage the symptoms, definitely.
Thank you. William's iPhone, you can come off of mute and ask your question.
Hi, thank you, Dr. Parmensha. Thank you so much for your presentation. That was great. I do have a question. You mentioned that 80%, the US is consuming 80% of the worldwide opioids, okay, of the opioids worldwide. What do you think these other countries are doing that they do not have this problem? And if any of whatever they are doing is applicable here in the US, if you have any information about that?
So I think, when I say 80% of the opioids consumed, it doesn't mean only prescription opioids. I'm talking about prescription opioids, illicit drugs that are circulating on the streets. So all that combined together is 80% of the global opioid consumption. But at the same time, we have to understand that because we are in a vicious cycle now, which started with increased prescription drugs, and then it went to patients getting more and more tolerant to the opioids and more needing the opioids, and the illicit drug market increased. And now when the illicit drugs were not working for patients, they are mixed with more potent drugs like remifentanil or carfentanil. And all this is fueling into the opioid epidemic, including the COVID pandemic that is fueling into the socioeconomic stressors and increasing this epidemic. So definitely that is one of the factors, big time illicit drug use. But the other aspect is multimodal pain management is still prevalent in most of the countries. If the patient's population is not as addicted or not as tolerant to opioids, so the low doses of opioids work, non-opioid medications work. Here, if the patient is tolerant, they will need more and higher doses of opioids. So that's where I think the difference lies. So right now we are in a cycle where we are experiencing a pandemic. So we have to curb this pandemic, make the population less tolerant to opioids, make them naive to opioids, so less doses of opioids will work.
Thank you. You mentioned something in terms of another question that came up, things that are mixed with opioids currently. As you know or have seen, xylazine is becoming increasingly found increasing now mixed with opioids. Anything you recommend in terms of prevention or a diagnosis as providers and the community may be seeing that more commonly?
I'm not too sure what xylazine is, but yeah, definitely a lot of IMFs are being mixed with opioids. IMF are, synthetically manufactured fentanyls, which are illegally manufactured. So these are fentanyl and fentanyl-like substances. Because they are more potent, they cause more high and more addiction and more need for the drug. They are being mixed. So the way to diagnose is to do a urine drug test. And we, as the members of Opioid Task Force, are promoting opioid urine drug tests at every encounter for the patient when they come in. And if you are suspecting, or if you see that the patient is using opioids, or they tell you that they're using opioids, do an expanded urine tox screen to see what is in the urine, because you don't know how to manage or how to treat unless you know what is in the patient's body.
Absolutely, thank you. And xylazine, just for the crowd, is a pet tranquilizer. It's an animal tranquilizer that we're now seeing being used mixed with drugs. Azalea, you can come off of mute and ask your question.
Thank you. This has been a great presentation. Did I hear the speaker say that Medicare is paying for acupuncture treatments, or yes, private insurance? I wasn't sure.
Yeah, Medicare is, probably think the private insurance normally follows what the Medicare does, so I'm sure they will be paying, but it is for low back pain. If you have a doctor's referral for 6 sessions, for low back pain, they are paying for it.
Thank you very much.
And final question, unless the audience has other questions that was sent to me, can you determine a PCP versus a specialist when you're talking about pain control? At what point should they be seeing a different doctor besides their primary care physician?
So that is a very good question. You know, it is, there are primary care physicians who are comfortable managing pain, and there are primary care physicians who are not comfortable managing pain because they are managing a lot of other medical conditions simultaneously. So at any point, the primary care physician feels that they are, or the patient feels that they are not getting the treatment they receive, they should ask the primary care for sending a referral. But there are certain pain conditions where we want the primary care to send us the referrals right away. Like patients who have an acute disc herniation, there is something that we can do which a primary care cannot do, maybe an epidural steroid injection that can change the course of patient's disease or change the course of how his functioning is going to be long term. Or patients who suffer from herpes zoster and have shingles and are having severe pain that is not being controlled with medications. So any patient where medications are not able to control the pain and they may need an intervention, we would definitely want them to be referred to us right away. There are patients with cancer pain, and if they are requiring high doses of opioid medications, where we can intervene and do an intrathecal pump, or we can provide a block to block this pain, those patients should be referred early on, and we would try to get them in the clinic as soon as possible.
Thank you very much. Are there any last minute questions before we close out? I don't see any in the chat. I don't have any more on my cell phone. If not, we'd like to give you a fantastic round of applause. I've gotten lots of comments in the chat about what a thorough presentation and a great presentation. So we thank you very much for joining us this evening on behalf of the Delta Research and Educational Foundation. Anybody who's not on our normal listserv, please feel free to put your email in the chat, and we'll keep you apprised of other events that come. And please feel free to complete the evaluation prior to your departure. But thank you very much for joining us. Everybody have a great night. And as I always end, if you have not gotten your booster for COVID, we recommend that you go ahead and get boosted. So have a great evening, everyone. Thank you very much for joining.
Thank you very much for giving me this opportunity.